The following video will cover the Columbia Suicide Severity Rating Scale, often referred to as the CSSRS screen. This video will explain this new screening tool in more detail and how to complete the CSSRS form in OneChart. Let's get started with the initial suicidal screening. We will cover the importance of screening for suicide, when a suicide screen needs to be performed, and the importance of using a standardized tool such as the CSSRS. To be most effective, a suicide risk screen should be performed on all patients at every encounter to a healthcare facility. Why should a suicide risk screening be completed at every point of entry? Suicide is a major public health crisis, and it's among the top 10 causes of death. Screening is an opportunity to save lives. For example, many adolescents that come to emergency departments for illness or accidents also have suicidal behaviors, but do not get identified. Why use the Columbia Suicide Severity Rating Scale, or Screener? Anyone can complete the short screener. No mental health training or education is needed. Using the CSSRS can help you reduce liability. It is the most evidence-supported suicide risk screen available. It is recommended by the Joint Commission, and there are clear guidelines for when to take next steps. The CSSRS removes the independent clinician's interpretation and utilizes an evidence-based standardized tool to help clinicians classify a person's suicidal ideation and behavior, determine level of risk, and make clinical decisions about care. Using the CSSRS and its uniform definitions can help ensure that the doctors and nurses at a hospital are all speaking the same language, leading to better and more consistent patient care. The CSSRS has a 99% reliability, which helps prevent and decrease the rates of suicide. The CSSRS is a comprehensive measure that includes only the most critical suicidal characteristics. Streamlining the questioning will help save triaging nurses valuable time by reducing false positives. You may be thinking, I've been asking my patients about suicide already, so what is actually changing? We will stop using the single question of suicidal ideations with the answers of none, intermittent, or constant. We will start using the Columbia Suicide Severity Rating Scale or Screener for all points of entry, which include the ED, OB, PEDS, ICU, Med-Surg, surgery, and behavioral health. You will continue screening for suicide risk upon admission at all points of entry.
Next, we will briefly review where certain departments can locate this new screening form. The CSSRS has been added to the admission or intake forms that you are currently using. This new screening form can be found within the tab titled CSSRS Since Last Visit. For those working in the emergency department, the CSSRS can be documented using the ED Triage Part 1 form for either the adult or pediatric patient. Both can be accessed via the Activities column on the tracking board. Within the ED Triage Part 1 form, there is one field titled Suicide Screening. Selecting the Document option will open the CSSRS form below. For staff working in the ICU or Med-Surg units, the CSSRS can be found within the Patient History Adult or Admission History Pediatric forms. For those working in the surgery department, the CSSRS has been added to the Surgical Procedural Intake and History form that you are currently using. Please note that the surgical intake form includes separate CSSRS sections for adult and pediatric patients. For staff working on the labor and delivery units, the CSSRS can be found in the OB Admission Assessment form. And lastly, for staff working in behavioral health areas, the CSSRS can be located within the BEH Admission History Adult or Pediatric forms. The CSSRS can also be located within the Crisis Evaluation form, which contains separate sections for adult and pediatric patients. If your patient is determined to be at risk of suicide based off of the CSSRS screen, continued reassessment will need to be done. All subsequent suicidal assessments can be documented within the flowsheet doc under the ongoing Columbia Suicide Severity Rating section, which is found within all system assessment bands.
Okay, so what is the CSSRS screener? It's a screener with a minimum of 3 questions and a maximum of 6 questions. These questions assess for suicidal ideation, ideation intensity, and the assessment of suicidal behavior. Questions 1 and 2 assess for ideations. Questions 3, 4, and 5 assess for ideation intensity, which includes intent with or without a plan. Question 6 assesses for behavior. Your patient's response to question 2 will determine if you will need to fill out questions 3, 4, and 5. Let's take a closer look at the initial screening for suicidal risk, which starts with assessing for ideation. All questions must be asked using the exact wording on the CSSRS tool. You must ask the first 2 questions to all patients. Question 1. Have you wished you were dead, or wished you could go to sleep and not wake up? Question 2. Have you actually had thoughts of killing yourself? We will first take a look at the path of least resistance. We will call this Path 1. If the answer to the second question is no, then you will move on to question 6, which asks about behavior. Note: you can see that after answering no to the second question, the choices for question number 6 will no longer be grayed out and are now available to document within. Question number 6. Have you done anything, started to do anything, or prepared to do anything to end your life? Why is asking questions about behavior important? Asking questions regarding behavior helps determine if a behavior is an actual suicide attempt. Okay, so how do I know what is considered to be an actual suicide attempt? The definition of a suicide attempt is any self-injurious act committed with at least some intent to die as a result of that act. The act does not have to be an injury or cause harm, just the potential for it. Some instances to consider include if your patient has collected pills, obtained a gun, gave away valuables, or wrote a will or suicide note. It also includes if your patient took out pills but didn't swallow any, held a gun but changed their mind, or the gun was grabbed from them, or if they went to the roof but didn't jump. This also includes if your patient actually took pills, tried to shoot themselves, cut themselves, tried to hang themselves, and so on. Now what? If your patient responds no to questions 1, 2, and 6, then you are finished. If your patient answers yes to question 6, you will need to review the reference text and your hospital's standard of care for your next steps. Let's go back to see what happens if your patient answers yes to the second question. We will call this Path 2. If the answer is yes to the second question, then you need to ask your patient questions about ideation intensity and behavior, which are covered by questions 3, 4, 5, and 6. Note: by selecting yes to the second question, the choices for questions 3 through 6 will no longer be grayed out and are now available to document within. Okay, now what? If your patient answers yes for questions 3, 4, 5, or 6, you will need to review the reference text and your hospital standard of care for your next steps. This concludes the video on the Columbia Suicide Severity Risk Scale.